Body weight and fat levels are regulated by a complex system of physiological signals. These signals control appetite, digestion, metabolism, and energy balance. These signals are dysfunctional in the obese person, working against attempts to lose weight or keep the weight off. To achieve significant long-term weight loss, the body's weight regulatory system, or metabolic health, must be reset so that the body will stop storing excess fat. New research indicates that bariatric and metabolic surgery has metabolic impacts that enable a new, lower set point, allowing the body to return to a lower body fat level. By altering the anatomy of the stomach or the intestine, bariatric and metabolic surgery affects hormonal signals, resulting in decreased appetite, increased feelings of fullness, increased metabolism, and healthier food preferences. These positive changes allow the body to lose weight without the internal fight to return to the higher set point.
For most people, weight loss of more than 5 or 10% is really beyond reasonable expectation. And any clinicians who've tried this would probably concur with that. You may see more weight loss in that short term, but it's seldom maintained. The only thing that breaks that boundary and gets you into weight loss of more like 30%, 35% is bariatric surgery. Surgery is the only thing among the various options that consistently promotes long-term weight loss, at least as much as 20 years in the best data, as opposed to the non-surgical methods, which are typically hindered by this nadir at about 6 months, and then people begin to recover their weight loss.
Let's discuss the surgical treatment options available. There are 3 main surgical procedures to be considered: the Roux-en-Y gastric bypass, the vertical sleeve gastrectomy, and gastric banding. A less prevalent procedure for a small number of patients, the biliopancreatic diversion or duodenal switch operation, is typically reserved for patients with severe metabolic syndrome. No single procedure is right for all patients. All of these operations can be performed laparoscopically, which means by a minimally invasive technique, providing for a speedy recovery and can have a better cosmetic result at the end of the procedure. Factors that need to be considered in deciding which procedure is the best option include age, lifestyle, eating habits, BMI, and more importantly, the presence of obesity-related diseases. For patients with obesity-related diseases and significant weight to lose, gastric bypass or sleeve gastrectomy are the options that offer the greatest weight loss. If the patient has a condition such as type 2 diabetes, hypertension, or high cholesterol, gastric bypass or the sleeve gastrectomy are the most popular choices. Gastric banding, a less invasive procedure, provides weight loss results, but less than with other procedures. The following videos show how each procedure is performed.
To gain access to the abdominal cavity, small incisions are created on the abdomen. Trocars, which serve as passageways for the surgical instruments, are placed into the incisions. The surgical instruments are passed through the trocars to access the abdominal cavity. The surgeon examines the abdominal cavity using a laparoscope or video camera. A small stomach pouch is created using a stapling device. The small intestine is separated into 2 sections. The lower portion of the small intestine is attached to the newly created stomach pouch. This allows food to pass directly into the small intestine, where digestion continues. The upper portion of the small intestine is reconnected to the lower part of the intestine. The bile and pancreatic fluids from the liver and pancreas allow food to be completely digested. By altering the anatomy of the gastrointestinal tract, gastric bypass changes signals in the body, resulting in decreased hunger and increased feelings of fullness after meals. To gain access to the abdominal cavity, small incisions are created on the abdomen. Trocars, which serve as passageways for the surgical instruments, are placed into the incisions. The surgical instruments are passed through the trocars to access the abdominal cavity. The surgeon examines the abdominal cavity using a laparoscope or video camera. The average human stomach can expand to hold around 1 to 1.5 liters of food. While in the stomach, food is mixed with digestive enzymes to help break down the food to a more simple form, so that it can be more easily digested and absorbed when it is in the small bowel. During a sleeve gastrectomy, a thin vertical sleeve is created by using a stapling device. This sleeve will typically hold between 50 and 150 milliliters, or is about the size of a banana. The excised portion of the stomach is removed. By altering the anatomy of the gastrointestinal tract, sleeve gastrectomy changes signals in the body, resulting in decreased hunger and increased feelings of fullness after meals. The bile and pancreatic fluid from the liver and pancreas mix with the food and allow it to be completely digested and absorbed in the bowel. There is no rerouting of the small bowel or post-operative adjustments needed for the sleeve gastrectomy. To gain access to the abdominal cavity, small incisions are created on the abdomen. Trocars, which serve as passageways for the surgical instruments, are placed into the incisions. The surgical instruments are passed through the trocars to access the abdominal cavity. The surgeon examines the abdominal cavity using a laparoscope or video camera. In preparation for the band, a tunnel is created behind the stomach. The band is introduced to the abdomen through a trocar. The band is positioned around the upper portion of the stomach and then secured using the locking mechanism. A tube attached to the band will be connected to the injection port. The port is used to adjust the band tightness after surgery. An incision is made on the upper abdomen to insert the injection port beneath the skin. The tube is secured using the locking connector on the port. The injection port and tube are placed beneath the skin. The band does not alter the digestive function. Food consumed passes through the digestive tract in the normal route. The surgeon may tighten the band by injecting saline into the injection port. As the saline is introduced into the injection port, it travels through the tube to the band. The addition of saline to the band creates a smaller upper stomach pouch. This smaller stomach pouch decreases the amount of food you can eat before feeling full.